Hi, everyone, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Kimani Hendricks, Multimedia Communications Coordinator for MS Focus. Our speaker today is Brittany McHugh, who will cover fall prevention and MS. We'll address all questions and comments after the presentation. Brittany McHugh graduated with her doctorate of physical therapy from the University of St. Augustine in 2011. She graduated with her Bachelor of Science in Athletic Training, magna cum laude, from the University of South Florida in Tampa. Brittany has been working at UF Health Outpatient Rehabilitation Services Department since 2012. She is one of the neurophysical therapists specializing in treating stroke, spinal cord injury, multiple sclerosis, Parkinson's disease, cerebral palsy, traumatic brain injury, neuropathy, and balance disorders. In 2018, Brittany became a multiple sclerosis certified therapist. She's also certified in Lee Silverman voice treatment, BIG for patients with Parkinson's, and has participated as a speaker for UF Health neurologic support groups. She has received her vestibular rehabilitation certification from Emory University and assists patients with vestibular dizziness disorders. We're pleased to have her join us to present this important topic. Dr. McHugh, thanks for being with us today, and I'll turn it over to you.
Okay, thank you so much, Kimani. Good afternoon, everyone. Thank you so much for joining me today. So I'm just going to minimize that to be able to get started on the presentation for you guys. So as you can see, the name of our topic today is Watch Your Step, Fall Prevention and Multiple Sclerosis. I have no disclosures associated today with this presentation. So to get started, I wanted to do a little activity, and I can't physically show this, so I wanted to be able to put it in Word format to go over this with you. So with having a patient, she's 66-year-old female, and she's walking without an assistive device, so no cane, no walker, etc. So I'm wanting to go over, with doing some different dynamic walking activities, how her walking speed changed. So with just walking normal at a comfortable pace, it took her about 6 seconds, so 1.7 meters per second. So in the grand scheme of things, if a patient is walking 1.0 or higher, they're doing very well when you're looking at the walking speed. So to put a reference on that. Now, when you're adding an obstacle, so I had them work on walking around cones, stepping over boxes, those types of activities. It now took her 11 seconds to do, so a little bit longer time to complete the task. As you see, her walking speed now went to 0.91. But then with also adding a cognitive mental task, so meaning multitasking. So how many times are we, we're walking, somebody's talking to us, we're, checking our phones, we're, doing, there's a bunch of people moving around. I know with what things are going on in the world right now, we're not necessarily out and about doing normal activities at the mall or grocery store, that type of thing with having a lot of people. However, if you had a bunch of people around and doing a lot of things at the same time, so with this task, what was instructed was to not only step over and around the obstacles on the floor, but also have to report to me something sticky. So she had to physically think of the topic for me before she could advance walking. So it obviously slowed her down to where now the walking speed was 28 seconds. So just walking normally, not having to think about anything, we're walking at 1.7, but now we're adding multiple things going on, and now we're down to 0.36. So I'm going to talk further about why, we're looking at walking speeds. It's a big factor in therapy on a fall risk. So this patient went from not a fall risk to a pretty high fall risk with adding all of these things going on. So to talk a little bit about multiple sclerosis, so it's defined as both an inflammatory and neurodegenerative disease. It's characterized by demyelination and several degrees of axonal loss of the brain and spinal cord. Common symptom complaints for patients are decreased sensation, so not being able to feel as well, decreased strength, spasticity or tone. So you may hear different terms with that, but oftentimes your patients are having a lot of cramping and that type of thing, lending for those issues and complaints. But also too, impaired balance as well as complaints with walking and their mobility is really a high issue for a lot of patients, up to 85%. So specifically with MS, it's going to impact the neurons being able to communicate with one another effectively, and impacts postural control and your balance, which I'm going to talk a lot about more later. About 2/3 of patients will report issues with their balance and coordination as really the main issue that's impacting their mobility. Now, also fatigue, muscle weakness, as well as the spasticity, as I mentioned earlier, will compromise the ability to have adequate balance and lending for more higher susceptibility of an accidental fall. So as I'm talking about falls, there is a difference. So whether you're characterizing something as a true fall or a near fall, so the difference. So according to a study called by Peoples et al., so a true fall is defined as an event which results in a person coming to rest unintentionally on the ground or lower level. Now, according to Fritz et al., a near fall, so a little bit different, is when an individual has a trip or stumble, but they're able to recover their balance. So even though you might not necessarily be fully falling on the ground, if you are having more of an incidence where we're tripping over our feet, we're stumbling to catch ourselves, we're still needing to be a little bit more concerned of maybe I have some balance issues, because it does still technically fall under the umbrella of that. Now, how common is the incidence of this? Well, actually, a balance impairment for patients is a very big issue, with about 50% of patients having an issue during a 3 to 6 months time frame, which is actually a really high incidence if you're looking over a short time frame. Falls are commonly happening during functional mobility tasks, such as walking, hence I was talking about the walking earlier, as well as transfers. So and that could be a variety of transfers. We've got to transfer and do different things in and out of the bed, in and out of the shower, the car, the toilet. There's all different areas of our daily activities that we have to transfer and do things. With multiple sclerosis, it does result in the postural instability, as I was mentioning before, and gait abnormalities, which is the technical term for we're having a little bit of a change in how we are getting around, how our walking mechanics are, lending for you're now at an increased risk for falls. So some specific factors that are associated with the multiple sclerosis population that lends for a higher incidence of falls is, for example, if you have had been diagnosed and had your disease for a longer duration of time, if you're on the more progressive side versus relapse remitting, so more of a progressive disease course. Any bladder dysfunction, so having issues with being able to get to the restroom on time, having any incontinence or any accidents, that can lend for some further issues with that if there's any bladder concerns. Also, as I was mentioning before, being able to mentally process and be able to strategize things. So having some issues with our mental status, with our cognition. So being able to remember things, know where our surroundings are, that type of thing. If that's impacted, that's going to give us some more issues. Greater disability scores. So specifically what that means is if the physicians are rating the individual based on their mobility, and all of that, there's a specific disability score. So if you're having a lower disability score, then that lends for a higher fall risk. And also, as I was mentioning before, so the walking speed has been a thread through this presentation so far. So if we're walking slower and having an increased issues with our endurance, that lends for some more issues as well. Postural control deficits, which I've mentioned prior, as well as if you're just utilizing a cane or a walker or something along those lines, it does impact you because you're having something else in your environment. Okay. So I've mentioned the difference between falls and near falls, and where things are occurring and how often is it happening, what are some susceptibility factors, but also where is this commonly happening. So one of the studies I was researching with this is that falls are typically occurring when we're doing more dynamic activities. So we've got tasking going on. So the main items that it was coming up to where it was really a higher issue is transferring outside your home. So if you think about it, you're in a different environment. You're not familiar with the surroundings. It's not a normal area for you to be managing. So there's more susceptibility there. Negotiating obstacles. So like I said, having to step over something, step around, you're not being able to have your normal base of support. It is going to impact you there. And lastly, just changing position. So having to just move around quickly, you've got a lot going on, it's going to be a higher incidence. But as you can see, some of the other items that are mentioned here, walking on slippery surface, that would probably be more of a fall concern for anybody when it's wet outside. But with stairs and other transfers as well inside your home, that things can typically happen there too. So how is this impacting our walking? So patients commonly with multiple sclerosis will tend to utilize a slower, wider step. So what is happening is your feet are wider apart because you're trying to help stabilize your issues with the torso, having weakness and decreased control for your trunk. So now we're having a wider step, and we're also taking a more cautious, slower speed normally. So even though it may seem that is helping because we're taking our time, our feet are apart, this should be a better strategy for us, it can actually lend for more instability and more incidents of falls, so believe it or not. Also, having to change your walking speed while completing, like I said, the multitasking is more predictive of falls. As I was showing before, that there was a significantly slower speed versus not doing anything at all. And as I was saying prior, the walking speed is really the main predictor that we use in therapy to determine the fall risk. So this diagram that I have is really just a flow to kind of look at, and if you focus it on the center where it's listing accidental falls. So if something were to happen, trip, etc., now we've fallen and hurt ourselves, and now we have an injury or have a broken bone, if you will. So now we are having a reduction in our mobility. We're a bit more fearful. It ends up having a cycle of now you're a bit more deconditioned because we're not want to go and do things, lending for just an overall cycle of events to where now you're more deconditioned, we're weaker. It can cause further falls because you're having further issues with now walking and transferring. So like I said, it just ends up being a downward spiral, unfortunately. So some statistics for you. So 56% of fallers and 44% of near fallers. So again, a reminder, true fall is fully on the floor. Near fall is we're tripping but catching ourselves. Are concerned about, being fearful of falling. However, only 17% of people who've had true falls and 12% of people that have had near falls have actually went to therapy for evaluation of their balance for fall risk. Surprisingly enough, rehab services is meant to aid in this prevention, but surprisingly enough, only 20% of patients have actually been evaluated. So it's a really low number if you're comparing to about 50 to 60% of patients are having concerns and issues, but only 20% have actually received help for this. So hence, I'm here to talk about this today. So fall rates with individuals with multiple sclerosis are greater than 50% annually, and injury or fracture rates, so broken bone rates, 2 to 3 times higher compared to somebody who's just the same age. 60% of individuals with multiple sclerosis will experience a degree of cognitive impairment. So reducing the speed of them processing information. So somebody's telling you something, you've got a lot of things going on, you're trying to multitask, people are moving around you, you're looking at your phone, people, there's a lot going on. It's taking a longer time to process, and therefore we are now at a slower speed and more at an increased risk of falls. Patients with multiple sclerosis will often present with both postural control as well as the cognitive deficits. So now we've got two things: decreased core and stability, as well as cognitive deficit, lending for an increased risk of accidental falls, greater level of fatigue, and a reduction in quality of life. Postural control and balance deficits can be managed by rehab for patients with multiple sclerosis. So as I've been mentioning before, that postural control is a deficit that's common in the multiple sclerosis population. So what is it specifically? What am I referring to? So your ability to have postural control is defined as the ability to uphold the body's center of gravity within its base of support while maintaining a specified posture, making a voluntary movement, or reacting to an external disturbance. So I know that sounds very technical, but really what you are trying to do is being able to hold your body's center of gravity, which is right in the torso trunk area, being able to hold that nice and steady over your base of support of your feet. That's really what it's defined as. So this is a picture for you to see. So your body naturally has three strategies that you utilize innately to catch your balance. So we've got the ankle, then the hip, then the stepping. So for me to further elaborate on this. So if you start losing your balance and your body starts swaying back and forth, you're going to notice that your ankles are going to start to kick in a little bit. You're going to feel those ankle muscles kick in if you're forward and back. If your body starts to sway a little bit more, you haven't caught yourself, you're going to feel it in your torso and your back to be able to help catch. So that's more of your hip. And then lastly, if we still can't catch our balance, our body is going to step. So it's just an innate strategy to help stabilize if we're not able to catch ourselves with utilizing the other strategies. Being able to maintain your dynamic mobility requires two parts, so both gaze and postural stability. So gaze stability is the ability to maintain your visual focus on an external target during movement. So being able to focus on a target while we're moving visually and not lose focus on that. It can help both your eyes and your inner ear associated with your balance. They work hand in hand to help stabilize when we're moving around. And then also with your postural stability, as I was mentioning before, it's maintaining the body's center of gravity over a base of support in any given environment. Balance control can be considered a fundamental motor skill and can be learned by the central nervous system. With training and practice, postural control strategies can become more efficient and effective. So hence, balance therapy or rehab can be able to assist these things. So I wanted to share with the group here. This is a balance unit that we actually have in the clinic where I work. Neurocom balance units would be, located around the U.S. You just need to investigate if a local therapy location to you would be able to have this. But basically what it is you can see the therapist is standing with the patient. He is harnessed in that. And what can happen is both the wall surround, so the colorful wall surround and the floor underneath him can both move. So it is designed to challenge your balance, but in a safe environment. It does give the therapist really good information objectively about how you are keeping your balance, what strategies you are having deficits with, and truly how to definitively cater a balance program for you and what you are having issues with. So I wanted to include it because we do have this equipment locally. So if there is anybody on here locally, to have them be aware that we do have this equipment here at UF Health in Jacksonville, Florida. So, and it really just gives overall data about the patient's postural control. So in conclusion, I just wanted to wrap this up to say that overall, it is critically important to provide early intervention to aid with decreasing a patient's risk for falls. And due to the progressive and unpredicted disease course of multiple sclerosis, it's very important to be tracking balance impairment complaints in order to intervene as early, as indicated for fall prevention and balance rehab. So I wanted to include this lastly to get involved with the balance program so that if anybody is local, they can be able to have this information to be able to know where to reach out to us. But I would recommend for those that are not, if you have had a significant amount of falls, rating in the last 3 to 6 months, if you've had a true fall to the ground or if you're noticing that you are tripping, having to catch yourself, having near falls, I would suggest that you either speak to, whoever's following your medical care, whether it's your primary doctor or your neurologist, and investigate with them and ask them, if they have the resources that can be able to send you to a physical therapy location for balanced rehab. So I really appreciate everybody's time today. And if there's any other questions, I can definitely feel free to answer. So I appreciate it.
Thank you, Dr. McHugh. To our listeners, there are 2 ways to ask questions. You can either type it into the chat box or use the raise hand feature to speak directly to Dr. McHugh. For that option to raise your hand, you click the screen to pull up the menu and select more, which is the icon with 3 dots. I'll unmute you and an alert will appear on your screen asking if you'd like to be unmuted. And that's for those of you who are on mobile devices, but everyone else who's using computers, you'll find the raise hand feature in the participants window. And while we wait for them to find the necessary features, I actually do have a question. I know that a lack of vitamin D can generate balance issues and that people with MS typically have that deficiency. Are there any studies that suggest an increase in vitamin D can reduce the fall risk?
Oh, that's actually a good question, Kamani. I'm not personally familiar with any specific studies on that with doing this research. To answer that question, I'm not familiar with any specific studies on that.
Gotcha. Because I remember reading somewhere that it was like for people who you're less likely to, I guess, get multiple sclerosis if you're more exposed to the sun and if you have more vitamin D in your diet, people with lower vitamin D are more likely to get it. And I know that I've heard because I remember thinking back to when I was a child, one of my grandmothers had a deficiency in vitamin D and she always struggled with balance. And so she didn't have multiple sclerosis, but I was just wondering if that was applicable to them as well.
Not that I'm aware of. But if I were to come across that, I will definitely let you know.
Awesome. Casey asks, how do you know if your house is part of the problem with falls, clutter, lighting, etc.?
Oh, that's a good question. So commonly what we'd recommend for patients, if you notice that you are having some concerns with your balance, I would commonly go over with patients having night lights, removal of loose rugs, being aware of your surroundings in and around the home, loose rugs and obstacles around the home on the floor if it's uneven, just needing to be a bit more aware of those areas that would lend for more of a fall risk. So normally, typically, if I do have patients that have those issues, I will recommend that they're removing the loose items on the floor, as well as considering to have a light on at night, because typically that is more of an incidence of somebody is getting up at night, they're not being able to see as well. You're already having some issues with your balance, so trying to utilize your vision to its advantage by having a night light, if that answers her question.
Mary, do you have a question?
Yes. Can you hear me?
Yes, we
can. Yes, ma'am, I can.
Okay. What I wanted to know is, I think my problem is the postural control. When I'm walking, I don't know, I find myself bouncing off the walls. I'm catching my fall by, falling into the wall or putting my hand up to the wall to block a fall. So would that be considered as, what is it, postural control?
So it sounds like you're having some near falls. So you're tripping over and stumbling, but being able to catch yourself.
Yes.
So you normally walk with a walker or a cane or anything?
I walk with a cane. I presently have had a knee replacement.
Okay.
Which now I'm finding that I can walk more without the cane, but my balancing is I'm concerned about. So I still carry the cane with me, but now you mentioned this post-urograph.
Posturography. Yes, ma'am.
Yeah, I need to get the correct spelling of that.
Oh, sure.
Because I want
Let me
okay.
Let me go back to the previous slide. Can you see that still there, ma'am, Miss Mary? Can you see the spelling there now?
Yes, I can. Hold on for one. I'm writing it
No
down.
problem. I can leave it there for you.
Okay, because I want to see, because I stay in Michigan.
Okay.
And I want to see, we do have a neuro physical therapy, but would I have to go to a neurophysical therapy to be able to to do this, or would any other physical therapies have this machine?
Typically it probably would be, you'd have to just investigate the locations, but I would suspect that it probably would be more at a location that the therapist is more specialized for neurologic disorders, since it is a balance unit. That doesn't necessarily mean that it wouldn't be in another location. But it does sound like that you're needing a little bit further investigation on your balance and how that they can best help you.
Because the place that I'm going to now, I saw a machine that was very similar to this, and it
very well could be.
Okay.
Different models. So they very well might have, this is just the picture of the unit that we actually have at my clinic. But there are different ones that I am aware of. They've come out with newer ones, I believe.
Oh, okay. So how would a therapist be able to determine which, like you said, near and the near fall, and what was the other fall?
Just a true fall, if you're fully going to the floor. Yes, ma'am.
Okay, so if you're going to physical therapy and you're explaining to the therapist what's going on with you, would they have to test you first to determine what type of fall you actually have, or could they just go by your explanation of what's going on with you?
Okay, so let me, I guess, elaborate on the topic there for you, Miss Mary, to see if this might help. So typically, if I have a patient that gets referred to me from the neurologist or the primary care, they're getting sent to me either having issues with their walking, or they've told the doctor they've had a fall, and then now they're coming to me as the therapist for further investigation on why is this happening. So for myself as a therapist, what I would do first is we would go through a normal physical therapy assessment. So that includes looking at your strength, your motion, testing your balance, not with the machine, but just other standardized measures that we use in therapy practice. as well as checking to see if you're having any deficits with your sensation, your coordination, being able to proprioceptively feel, just kind of seeing if you're having any other neurologic deficits due to the MS in the first place that could be lending for more of a higher susceptibility of falls. And then normally, typically what we would do after that is to say, okay, let's also do this balance unit testing. But for those that are listening, this testing for a patient, they have to be able to stand there without holding on. So if you are somebody that does need physical assistance to stand, or you'd have to be able to hold on to something without having a loss of balance, then the testing wouldn't be appropriate. But that does not mean that physical therapy for your balance is inappropriate. I would definitely recommend that, and if that's the case. However, though, with this balance testing, you do have to stand without holding on to anything. And the therapist is there with you, but it is meant to challenge your balance. It gives the therapist information on how are you keeping your balance. Are you primarily utilizing your vision? Are you primarily utilizing your ability to feel and sense your surroundings? Is that your primary strategy? And also your inner ear, so your vestibular system, if you've ever heard these terms getting thrown around. So your body utilizes those three systems along with your ankle and hip and other balance strategies. The two concepts work together to help yourself stay stable. So it gives us an objective data printout that shows us how did you keep your balance whenever it was challenged. And then the therapist would cater a balance program and exercise setup for strengthening specific balance exercises catered towards what deficits you are having and working towards your functional goals. So that is commonly the approach for balance therapy. You're coming to physical therapy if you've been having balance complaints. Does that help clarify some things, Miss Mary?
Yes, it does.
Oh, good.
Thank you.
Yes, ma'am, not a problem.
Our next question.
Go ahead.
Our next question comes from Myrna. She asks, will practicing walking heel to toe or walking in a line help create a better balance for the brain?
It's a challenge. As far as for me to say specifically to work on that without having assessment, I would be a little leery. So if you are somebody having some deficits or complaints, I would recommend to check in with your physician or to see if they've referred you to a therapist first. But yes, if you are just in general walking in tandem or walking one foot directly in front of the other is a more narrowed base of support, which is more challenging for your balance. So it is something that is commonly done for training. But Ms. Kamani, can you say that again, the full question? I'm not sure if I've missed not answering something else for her fully.
Myrna just said, will practicing walking heel to toe or walking in a line help create a better balance for the brain?
Okay, so as far as, I mean, it is a strategy that is utilized or an activity that is utilized. I would just want to make sure that you would be safe executing that task with having an assessment or at least seeing your physician or a therapist prior to doing that.
Okay. Deb, I'm glad I hope you're feeling okay. Deb says that she fell last week when a dog she was watching ran right in front of her. But yeah, be careful, Deb. We need you. Casey asks, is it okay to use a wall for balance, or is that the point where you need to start seeing someone for help?
Normally, if I'm having a patient come to me and they're telling me, oh, well, I caught myself and I don't, have a cane or a walker because I just use the walls, then yes, that normally is a concern. And typically I would recommend to a patient, and we'd want them to have a referral to be able to come to therapy to have that better assessed. And the physical therapist would also be able to investigate an assisted device with you to determine what might be a safe fit, whether a cane walker, etc. I know it can be a little intimidating when we're trying to be as independent as possible, but normally, typically what I would do with my patients is would try and have them be as independent as possible and not limit them. However, I'm also wanting them to be safe. So I try and explain to them that this might be a temporary thing, but we're really just trying to have you be as safe as possible. So I guess to follow up and answer your question, I would seek out assistance if you notice you're really wanting to grab onto the wall for your balance.
So there's a question and a comment from Lydia. She says she tore her ligament in the right ankle years ago, and that's the leg affected by MS. And she says her ankle is weak and just gives out, which is why she falls. And orthotics facilities recommend AFO, and she wants to know if AFO limits that.
If AFO limits, okay, if I'm understanding the question correctly.
I'm sorry, she said she still wants to have full use of that muscle that remains in her leg, and will AFO limit that?
Oh, okay. So as far as the goal of an AFO is to provide outside stability. So unfortunately, if you have had some instability in the past from having a ligamentous injury, unfortunately, once it's kind of like a rubber band, once it's been stretched out, it doesn't go back to its original state, unfortunately. If you're having incidents there and now we're having some weakness from the MS, with the AFO, it would still allow you to utilize that foot to the capacity that you would want to. It is going to lend for that you're safer with walking. However, I have had patients over time, they may notice that their body becomes more reliant on the AFO, and they may notice further weakness just from further use, but it is going to not necessarily hinder the muscle. It will help with providing improved stability and assistance to that weaker area.
There's a question from Alma. She asks, what level of balance issue is inadvisable for one with MS, like to get on a horse for therapeutic horseback riding?
I'm sorry, Kimani, can you say that for me one more time? I'm so sorry.
Alma asks, what level of balance issue is inadvisable for one with MS? And I'm guessing she's using an example as if you were to do therapeutic horseback riding.
I guess if I'm just trying to fully understand if she's her question.
Yeah, I'm reading it verbatim, so I'm not entirely sure if she's using the therapeutic horse riding as an example, but the question, I suppose, is just what she said first. What level of balance issue is inadvisable for one with MS?
I mean, from what I'm taking from it, as far as what level of balance impairment to where it wouldn't be safe to do the horseback riding, I would say if you are needing to having physical assist and aid along with an assisted device, I would say at that point, and or if you're primarily at a transfer level mobility for your balance, needing that you're just sitting on the edge of the bed, we're having a hard time in tipping over. I would say if that's our mobility level and deficit, then I would say it would probably be a lot harder to be able to do the horse therapy.
No problem. Thank you for answering that.
Okay, I hope that helps. I hope that helps answer the question.
Too, as I really didn't understand it. But Lisa, I see your hand up, so I'm going to unmute you here.
Thank you. I currently have for a long time taken 4-aminopyridine, which is the compound formula of Empira or Empire. It helps enormously with my walking. I know if I don't take it, I'm in big trouble, but I can do a lot because of it, and a lot of other things, fatigue. But does it help with falls? I have had some falls, but is it helpful have you had people that have fall issues that have gotten help by taking the 4-aminopyridine or the Empira?
I have had patients that pardon me, that have been on the Empira, as far as just noticing that it's helping with their overall walking. So, you know, sequentially to be aiding their falls, I haven't had, or their lesser occurrence of falls. I have not specifically had a patient of mine that had, you know, just from taking the medication had an improvement in their balance. I would say if I'm understanding your question correctly, and you can feel free to interrupt me, to where I would anticipate that there might be some other causes versus just the walking speed. If the walking speed is doing better with the Empira, but you're still having some issues with your balance, without doing an assessment, there could be some other things going on. So proprioceptive coordination deficits that could be lending for it. I'm not sure the scenarios where you had a fall, other weakness and strengthening need to be done to help with that. But I guess in answer to your question specifically, I haven't had a patient say by being on Empira, I've had better balance.
Okay.
So
Thank you.
Yes, ma'am.
Myrna has another question. She asks, if you practice what you can't do, for example, climbing stairs, can you get better?
I mean, as far as commonly in therapy, that's what we are, you know, working on, is asking a patient, okay, what are you physically having difficulty with, and then trying to help simulate that. So the repetitive training of stepping over something, practicing stairs, working on other strengthening tasks to then aid somebody having a difficulty with, like you're saying, a specific activity. Doing task-specific training is meant to help improve that. But again, wanting to make sure that you're doing it in a safe environment and under the appropriate supervision. I don't want anybody to hurt themselves.
Right. There's a question from Michael. I'm going to assume he means a knee, ankle, foot brace. He says, should he exercise with it on or off?
If they're referring to commonly, you know, an elbow or other knee, you know, leg stability device, normally for safety purposes, if somebody is doing standing activities, then yes, we would want to make sure, because the brace is meant to give more stability in standing. If you're doing seated or exercise laying down, it's not necessarily that you would need to have your brace on for that, but for standing activities, I would recommend that.
Yes, he meant the CAFO brace. Yes, thank you, Michael.
Okay.
That's what I thought. There's a question from Ronald. He has a comment. He says he's had MS for more than 25 years, but generally responding to medication and doing well. He said he fell while riding his bike a year ago. He hurt himself and he has no recollection of what happened. And a year later, he lost his footing in the shower and fell outside the tub, striking his head on the toilet. And he says beyond those incidents, he feels like he's doing fine, but should he pursue therapy? And if so, what type?
I would say based off of that, I would recommend having him reach out to either his primary care or neurologist about those incidences. And if anything, I would recommend at least reaching out to be able to be seen for an assessment, so they can be able to see if there's any other underlying causes that could be resulting in that and needing a therapy for that.
Yeah, he says when he struck his head, it resulted in subdural hematoma.
I would say definitely in that case, I would definitely recommend he reach out to request going to therapy for sure.
With that said, that's all the time we have for now. If you did miss any part of this conference, it will be available on demand on our MS Focus SoundCloud page, our msfocusradio.org, and Multiple Sclerosis Foundation YouTube channel. It'll be on the YouTube channel in a few weeks. Please be sure to follow MS Focus on Twitter, Facebook, and Instagram for times and access information. And our next conference will be Tuesday, September 29th at 5 p.m. Eastern Time with patient and MS advocate Sean Feliciano. So I thank you to the attendees for participating, and I thank you, Dr. McHugh. We appreciate your sharing this information with us today.
Thank you, everyone.